Nursing care of cognitive disorders. Module 2, Dementia and Pseudodementia. In Module 1, we discussed acute confusion and delirium. In this module, we shift to chronic cognitive decline. Dementia, now referred to in the DSM-5 as major neurocognitive disorder, represents a progressive decline in memory and other cognitive domains that interferes with independence and daily functioning. Unlike delirium, dementia develops gradually and does not dramatically fluctuate throughout the day. As nurses, it is essential that we recognize early signs, differentiate dementia from delirium and pseudodementia, and support both patients and caregivers with safety, dignity, and structured care planning. Major neurocognitive disorder is characterized by significant cognitive decline from a previous level of functioning in one or more domains, including memory, language, executive function, attention, perceptual motor skills, or social cognition. The key distinction is that these deficits interfere with independence in everyday activities. Mild neurocognitive disorder involves modest decline but preserved independence. Unlike delirium, dementia has a gradual onset, progressive course, and a generally clear level of consciousness until late stages. This difference is high yield for NCLEX and critical for bedside recognition. Alzheimer's disease is the most common form of dementia and typically begins with gradual short-term memory loss followed by progressive cognitive decline. Vascular dementia often presents with a stepwise pattern of decline and is frequently associated with a history of stroke or chronic vascular disease. Lewy body dementia is characterized by early visual hallucinations, fluctuating cognition, and Parkinsonian motor features such as rigidity and slowed movement. These patients are highly sensitive to antipsychotic medications, which can experience significantly worsening extrapyramidal symptoms, accelerate cognitive decline, and increase mortality risk. Frontotemporal dementia often presents first with personality changes, disinhibition, or language impairment rather than memory loss. For NCLEX preparation, remember, early visual hallucinations combined with motor symptoms strongly suggest Lewy body dementia. In early-stage dementia, patients may demonstrate mild memory loss, word-finding difficulty, and subtle executive dysfunction while remaining largely independent. In the middle stage, confusion increases, behavioral disturbances may emerge, and assistance with activities of daily living becomes necessary. In late-stage dementia, patients experience severe cognitive impairment, loss of verbal communication, total dependence, dysphagia, and increased risk for aspiration and infection. Nursing care evolves as the disease progresses, with increasing emphasis on safety, comfort, and quality of life. In older adults, depression does not always look like sadness. It often presents with fatigue, weight loss, sleep disturbance, pain, and memory complaints. Because cognitive symptoms may be prominent, depression in late life is frequently mistaken for dementia, a phenomenon known as pseudodementia. Pseudodementia typically has a more rapid onset, developing over weeks to months rather than years. Patients tend to emphasize their cognitive deficits, frequently respond with, "I don't know," and may give up easily during testing. In contrast, individuals with true dementia often minimize deficits, attempt to compensate, or confabulate when unsure. Another important distinction is sequence. In pseudodementia, depressive symptoms precede cognitive changes, whereas in dementia, cognitive decline comes first. The most important clinical clue is reversibility. Cognitive function improves when depression is treated with antidepressants and psychotherapy. However, it is important to recognize that late-life depression can also be a risk factor for future neurocognitive decline, so reassessment after treatment is essential. For a deeper review of depressive symptoms and treatment considerations, please refer to the microlearning video Mood Disorders series, Module 1, Major Depressive Disorder. Nursing assessment must be comprehensive and functional. Evaluate baseline cognition, ability to perform activities of daily living, behavioral changes, medication burden, safety risks, and caregiver strain. Screen for depression and suicide risk in early-stage dementia. Use structured tools such as the MiniCog, MoCA, MMSE, and geriatric depression scale as appropriate. Always ask, what has changed? When did it begin? How is this affecting independence? Behavioral and psychological symptoms of dementia include agitation, wandering, paranoia, hallucinations, aggression, and sundowning. It is essential to remember that behavior is communication. Before labeling a patient as agitated, assess for pain, infection, constipation, dehydration, sleep disturbance, or environmental overstimulation. Sedation is not the first solution. Identify triggers, modify the environment, use behavioral strategies first. Nursing interventions focus on safety, structure, and communication. Maintain fall precautions and remove environmental hazards. Use simple, one-step instructions delivered calmly and clearly. Avoid arguing or forcing reality orientation when it increases distress. Establish consistent routines. Provide familiar objects and reduce overstimulation. Support orientation with clocks and calendars while respecting emotional experience. Behavioral interventions may include redirection, validation therapy, reminiscence therapy, and music therapy. Caregiver education is essential. Teach families about disease progression, safety planning, behavioral triggers, and available community resources. Encourage respite care and support groups to reduce caregiver burnout. Older adults with cognitive disorders are vulnerable to polypharmacy, falls, dehydration, malnutrition, elder abuse, social isolation, and financial exploitation. Nurses must consider cultural factors, health literacy, transportation access, and advanced care planning. Holistic care extends beyond symptom management and addresses dignity, autonomy, and quality of life. For NCLEX preparation, remember, if the onset is sudden and fluctuating, think delirium. If the onset is gradual and progressive, think dementia. Altered level of consciousness suggests delirium. Clear level of consciousness suggests dementia until late stages. Delirium is often reversible if the cause is treated. Dementia is typically progressive. Dementia profoundly impacts patients and families. While there is currently no cure for most dementias, nursing care significantly influences safety, function, and quality of life. Our role includes early recognition, structured assessment, behavioral management, caregiver education, advocacy, and interdisciplinary collaboration. Preserving dignity and supporting families is central to excellent elder nursing care. For NCLEX preparation, remember that medication management is part of comprehensive care. To review cholinesterase inhibitors, NMDA receptor antagonists, side effect monitoring, and patient safety considerations, please refer to Psychopharmacology, Unit 6, Memory-Enhancing Medications, Nursing Monitoring, and Patient Safety. In the next module, we will explore safety risks, suicide in older adults, elder abuse, and ethical considerations in cognitive disorders.